Next, we have a GCDC oration chaired by Professor S. Venkataraman. Speaker, Professor R.S. Arulrhaj Sir, MD, PhD, FRCP, MBA, Head, Acute Medicine, Dr. Arulrhaj Institute of Medical Services and Sciences, Tuticorin, immediate past National President, API. We'll be discussing on the topic Cardiodiabetic Blockbuster, SGLT2i. I request our chairperson, S. Venkataraman Sir, to honor our speaker, Dr. Arulrhaj Sir, with the GCDC medal. GCDC Oration Medal. Over to you, sir.
Good morning to all of you. I joined the organizing committee team in welcoming all the faculties and participants of GCDC 2022. Now we have a very interesting topic today. After listening to Dr. Narasimhan, we all understand how important is lipids. See, why we focus on diabetes? We focus because of its complications. The common complication which either reduces or hello, not moving. Yeah, sorry. The common complication that takes away is the vascular complication. It can be either in the coronary artery disease or cerebrovascular disease or peripheral arterial disease or renal vascular disease. Therefore, today's drugs are positioned to have a take on these vascular complications. And the major risk factor for reduction as well as morbidity in life is cardiovascular system. Now, the incidence of diabetes is going on increasing, all of us know, for 1, 2, 3, 4 reasons. Now, drugs are being positioned in a different way to manage the complications also. In that line, our SGLT2 inhibitor is there. I'll just briefly go through the cardiovascular risk in outpatient scoring in India. When you see the patient first, the risk stratification is done by the age, gender, risk habits, diabetes, dyslipidemia, hyperlipidemia, and the CT angiography showing a lesion in the coronary artery. Based on that, this is the risk scoring. People with T2DM silently 100% have a coronary vascular disease risk. And with there is a moderate risk and high risk, and prior CV events have a lesser risk. This is the area. And there is a bilateral relationship between kidney and heart, both in the vascular system and in the endothelial systems. And the kidney plays a vital role in glucose homeostasis. That is, it is causing a gluconeogenesis. That contributes to 25% of the total glucose in the body. It also uses about 10% of the dietary glucose, thereby it is reducing its utility. It has a role on the glucose production, utility and reabsorption. There we come and land on our SGLT2 inhibitors. What is SGLT2? Very briefly saying, the National Institute of Diabetes and Digestive and Kidney Disease supported, through research, they discovered a gene in the intestinal glucose transport system. They are called as sodium glucose co-transportase or SGLT. In that there are two things are there, SGLT2, 1 and 2. One is mostly, present in the intestinal mucosa and the proximal convoluted tube also. Whereas 2 is mainly present in the, proximal convoluted tube, and this is responsible for 90% of the, glucose reabsorption. Whereas the 1 is responsible for about 10% of it. And coming to the SGLT2 that we are going to talk about it, Its main role is to reabsorb the glucose from the proximal convoluted tubes. And when we want to reduce the blood sugar level or hyperglycemia, we thought, why don't we try to inhibit this reabsorption so that the blood glucose level will come down. It's a differently focusing the methodology of action of a oral hypoglycemic agent. All of them are insulin based. This is non-insulin based. When this is prevented, the blood sugar level or hyperglycemia comes down, but it causes a glucosuria. Glucose goes down in the urine. That is where a few complications come, which we will discuss about it. The 90% of the glucose is being reabsorbed in the proximal convoluted tubule, and about 10% is in the S3 segment of it. And the 90% is handled by the SGLT2, and SGLT1 handles the 10%, as I told you. And there is an altered renal glucose control in T2DM. As we have discussed, if you go on into it, there is an increase in the glucose neogenesis and an increased SGL2 and its activity and an increased renal threshold. They all contribute to the hyperglycemia. This is what we have seen in the proximal convoluted tube. In the proximal portion, 90% is reabsorbed. In the S3 segment, 10% is reabsorbed. This is the overall clinical benefits of SGL2 inhibitor. It is not only reducing the glucose level, it reduces the blood volume, it reduces the sodium transportase, as well as it reduces the uric acid, creatinine, urea. These are all the benefit that is being given to the patient. And currently we have in India 3 groups of drugs, EMPA, CANA, DAPA. All are given single dose, and hemogliflozin is on the way, and other agents are ertugliflozin and FDA approved, but still has to come to India. In Japan, these are the other agents which are available. When there is an SGL2 inhibition, there, as I told you, glucose urea, the glucose is coming down. There are certain changes in non-alcoholic fatty liver disease. In the myocardium, we know there is a myocardial fibrosis is prevented, remodeling is prevented, and renal side decreased fibrosis and improvement in the EGFR. There are any number of studies which we can keep on quoting, right from 2014 to 2021. Now it's here only 20 and 21. There is a EMPA study, CANVA study, DECLARE or CREDENCE or DAPA heart failure study. All of them have proved that there is a promising role of SGL2 inhibitors in T2DM. This is a comparison of the effects of the gliflozins. Here all of them have almost equal efficiency only in reducing the blood control, blood sugar control, fasting and postprandial, weight management, BP systolic and diastolic. The cardiovascular benefits in terms of MACE, maximum adverse cardiac events and heart failure or CV death, in all the three there is a reduction. Both in heart failure, CV death or MAC, that's a relative risk reduction study. In all the 4 major global trials, it shows a gross reduction. This again says the heart failure, both in preserved and reduced ejection fraction, it is effective. In the dapagliflozin, the outcomes benefits are observed in heart failure with reduced ejection fraction irrespective of the diabetic state. Now slowly another concept is coming in. You don't need hyperglycemia or diabetic state for the gliflozins to act. Irrespective of the T2DM status, it can be. We will see that subsequently also. It's a study with dapagliflozin on heart failure. Compared with placebo, it is very well reduces the heart failure incidence. And in coronary artery disease, single vessel disease, multi-vessel, so past CABG or MI, in all of them, the empagliflozin has been found to reduce the cardiac events. And this is again another study in patients with other vascular diseases, peripheral arterial, prior stroke, prior heart failure, and presence of atrial fibrillation. All of them are being reduced compared to placebo. This is a major adverse cardiovascular events, as I told you, and then cardiovascular death and hospitalization for heart failure. If you see any, hospital in the emergency room, now today the maximum admissions are not for an acute coronary syndrome. Maximum admissions are for, recurrent occurrence of heart failure. This hospitalization status is, very much reduced. There is another recent study that EMPA heart study shows the ventricular remodeling after a myocardial infarction or a hypertension. There is a ventricular remodeling happens, and thereby the LV function is reduced, which is being controlled with this gliflozins. And there are renal benefits also. In the renal benefits, all the 4 cases, the eGFR is definitely found to be improved. Further reduction is controlled, creatinine comes down. Another important study says, I will come to it, uric acid excretion also goes out. Thereby renal lithiasis is being reduced. In DKD management, as I told you, eGFR decline reduced, serum creatinine, uric acid are reduced. And in DAPA CKD trial also, dapagliflozin is efficacious both in diabetic and non-diabetic chronic kidney disease. Now slowly we are shifting over to, from DKD to CKD, even without diabetes. That is a recent change. In DKD they are indicated to reduce the risk of sustained eGFR decline. That is a progressive decline in the renal functions can be reduced, and end-stage kidney disease can be used, and a decrease in the cardiovascular death and heart failure hospitalization. And this is the one that, this empagliflozin study has reduced the incidence of renal lithiasis. This is a very recent study that I got it, I have added it. And another important effect is on erythropoiesis. In chronic kidney disease and chronic heart failure, now there is a regime, replace the hemoglobin, with iron. I think Professor P.C. Manoria will agree with me. All heart failure, when we control, we give them intravenous iron because anemia is a common cause. And in renal disease also, anemia is a major important factor, Darjan and any type of iron. But if you give an GLT2 inhibitor, it improves erythropoiesis. Another effect is on the liver. Liver fibrosis, non-alcoholic steatohepatosis improves, prevents it from going into, liver fibrosis, and then cirrhosis liver, and it reduces the hepatic fat content. How it does? Fat is being removed, and it prevents a fibrosis also. And there is also another important thing, that is the left ventricular muscle mass. In people with obesity, hypertension, it definitely reduces it. Now we have talked about multiple beneficial effects of the gliflozins in diabetes and other metabolic syndromes. What are the adverse effects? One important adverse effect is genitourinary mycotic infection because of the glucosuria. And if there is an infection in the lower limb or fractures or amputation, we will have to be very, very cautious about it. Now these are a few contraindications. One important thing that I have marked is severe renal impairment. We say that it is useful in preventing the decline of the eGFR, but don't put it on a severe heart failure when eGFR is less than 40 or 45. This caution we need to keep it in mind. All other AIC, everybody says that SGLT2 inhibitors can be considered independent of the HbA1c. You need not wait for HbA1c to be more than 9 or 8. Irrespective of it, can be used. This also an ADA guideline is there. And this again EASD guidelines are there. The standard guidelines of ADA now say that these gliflozins are very useful in reducing heart failure and preventing continuous decline of renal function. Now where all we use, there are multiple situations we have listed here, but I would like to stress, when there is an established cardiovascular disease, one of these gliflozins should be the drug of choice. Secondly, when there is a microalbuminuria, don't wait for a renal urea and creatinine to go up. Even when there is a microalbuminuria, you should consider an eGFR when it is around 60 itself, you should think about it. Where we should avoid, when there is history of peripheral arterial disease or a foot ulcerations or previous fractures, we need to be cautious. Where we should not use a previous limb amputation or existing diabetic foot disease with ulcers and excessive alcohol intake and type 1 diabetes mellitus, we should not use at all. This is the overall place of this drug in T2DI management is diabetes control, renal protection, hospitalization reduction for heart failure, and major adverse events reduction, and we can always use it. These are the various ways of hyperglycemia which we have seen. One important thing is a renal reabsorption, wherein this gliflozin play a key role. Now, ladies and gentlemen, we are coming to the conclusion. You may all wonder, I labeled this communication as a cardio-diabetic blockbuster. It's a blockbuster, has a greater role today. It's a unique mechanism of action, which is different. It is not based on insulin, compared to insulin and other OHAs. It's complementary to all existing anti-diabetic drugs. Insulin-independent action, potent glycemic control, less hypoglycemia, good safety and tolerability, extra glycemic effects, or cardio-diabetic protector. We are today talking, we are sitting in a group meeting on cardio-diabetes medicine. All of us know cardiology. P.C. Manoria is here. All of us know diabetology. Professor Sesha is here. But we want this link because it is linked on patient. Whereas these specialities are coming parallel. We want them to transact. Here a renal hepatic protector, fat reduction, weight loss is there. Fat is reduced. When fat is reduced, fibrosis is reduced. That is why cardio-diabetic blockbuster is SGLT2 inhibitor. Thank you, ladies and gentlemen. Any inputs I will love to hear and learn.
Thank you, Professor Arulrhaj. I think it was fitting to be a great oration. I was just wondering how you are going to do justice to the topic in 17 minutes. Such a huge topic. And just a couple of points.
Please.
I think before these molecules, whenever we talked about a therapeutic molecule in the context of diabetes, we used to be very tentative. We used to say this molecule is cardiovascular safe. So, from a position of talking about cardiovascular safety to talk about a molecule which has been consistently proven in various RCTs as well as real world data that you nicely captured, to have consistent beneficial effect on heart failure, CV death and renal outcome, and of course with EMPA, with CV death as well in the post-hoc analysis. I think this is a great moment for all of us who are involved in the practice of diabetology, because we can keep our heads higher up and then tell our cardiology friends, okay, we donate this molecule to you because of the benefits. So at the end of the day, we want the patients to be benefited.
Yes.
And as you nicely alluded to, I think it's a beautiful class of molecules. I would say that all diabetic patients should be on this class of molecules unless there is a contraindication, which you also rightly mentioned. You went into all the details in such a short span of time. Hats off to you. A marvelous oration. Being an oration, I understand that may not be much questions allowed, but probably...
Any inputs from the senior diabetologist, cardiologist, I love to learn, because still there are many points here. When there is a high renal decline of EGFR, is the way out. And especially in women with a diabetes and cardiovascular, when you start that, your urogenital infections is very common. They are not able to continue. In those situations, is there a way out that anybody has it? I would love to learn.
Actually, to be very frank with you, when these molecules were introduced, I think all of us were part of, right from the introduction till now, we have been associated with academic aspects. We as clinicians were very, very apprehensive. Initially, we thought how this class of molecule is going to fit up in the Indian scenario, Asian scenario, with so much of dehydration. Now, you have learned that, number one, they not only tolerate it better, the effects are probably much more in the Asian and the Indian population compared to the Westerners like your GLP-1 receptor agonist or the incretin-based therapy. I think that's a good thing that we have learned about this molecule. Second thing is, I think with respect to the permissibility of the EGFR, probably we do have some guidelines wherein if you're going to have a good follow-up, even though EGFR 45 is being cited by some other guidelines, because you have data wherein patients have been recruited with the EGFR of 25 and 20. In fact, in EMPA kidney as well as DAPA CKD, compared to Credence, the recruitment baseline EGFR is less than 30. So even though one may not have the guideline or the confidence to start, I think having started with a comfortable level of EGFR and then following up these patients, we need not be panicky enough to stop them once they shift to CKD 3B or even 4.
I agree with you. Needs only lack of panic and follow-up. Sir, Professor Sesha, sir, have any comment? Quickly, he has already given it. Okay. Like Manoria, you would like to add something? Now this drug has been totally pocketed by cardiologists. Our cardiologist, every day, somebody gets it. Whether they are diabetic, non-diabetic, he puts it them on. Yes, please.
SGLT2 inhibitors are a panacea for heart failure. Take SGLT2 inhibitor daily and keep the heart failure away. And it is a boon for CKD because it slows down the trajectory of CKD and postpones dialysis by 10 to 15 years. That's what we want.
Thank you, sir. Always I used to say, in a diabetic fellow developed a coronary artery disease, we are not worried. When he has a decreased EGFR and urea is high, he is stuck. Because no procedure interventions can go on. Unless urine goes out, his failure will not go. Here it has a role. Thank you so much. Thank you very much.
Thank you all, and thank you, Professor.